Hi, everyone. Thanks for coming to the 1:30 session, and I know that you had many things starred, so I appreciate you being at this star. It was kind of you. My name's Ruth Potee, and like most of you, I'm a family doctor, primary care doctor who does addiction work, and I am an everyday seeing patients doctor. And our talk is on WTF methadone, and you can interpret that any way you want. We talk about the future, but to get to the future and what we maybe would like to do with methadone, we need to talk about its past. So that's where we're going to start. We're going to sit a long time there, and then we're going to talk about methadone. And I'm going to ask questions to y'all, and I'm going to, people, please shout things out. I'm all by myself up here, if you can't tell. So that Q&A, you're welcome to put a question in it. I can't monitor it. No one's monitoring it. And at the end, to be honest, let's maybe just ask questions, if that's okay. And you can write your Q&A in there to remind yourself, but there's only so much I can handle. So I'm the medical director of a bunch of OTPs and an OBOT and residential homes and withdrawal management programs, and I'm the medical director of a small county jail in Western Massachusetts. And we were the first methadone clinic licensed jail in the country. We did that in 2018. I have no disclosures. These are the learning objectives. I'm not going to review them. They're written. You can review them yourself. I'm dedicating this talk to my friend Paul Bowman. He was a friend of mine. He was a person in long-term recovery, and he was a person who went to methadone clinics, to OTPs for over 20 years. And he is the one who taught me to be outraged by methadone clinic rules and regulations. And I am rageful every single day, quite honestly, and I run these places. I'm the medical director, and I am furious about the care that I personally provide. I'm going to start with that. Paul died in November of 2021 of an overdose. So this is to Paul. Okay, here's my one stressful thing is I got to get this video to work for y'all.
Fine. Ladies and gentlemen, I'd like to summarize for you the meeting that I just had with the bipartisan leaders. I began the meeting by making this statement, which I think needs to be made to the nation. America's public enemy number one in the United States is drug abuse. In order to fight and defeat this enemy, it is necessary to wage a new all-out offensive.
What did somebody just say? That worked, thank you. Yeah, there you go. There was your dose of Richard Nixon in the beginning of the war on drugs, although actually it was well in advance of that, and we'll talk a little bit about that. That press conference was 1973, and President Nixon started this, that press conference was 1971, and it was from that was the origin of all the rules and regulations on methadone, which were written into the regulations in 1973. And this war on drugs is really a war on humans, and it's a war on brown and black-skinned humans more than anyone else in this country. And you can see that the increase starts in the 1970s. It really starts to peak again in the 1980s under Reagan, and then in 1994, and basically the three strikes rules. And we have caused more harm to society, more harm to individuals, more harm to family because of that trajectory that you see on that graph. And as a medical director of a jail, I feel tremendous amount of shame about that. Our country incarcerates more people than any other country in the entire world, and the top 15 states incarcerate more people than the next country. 15 states are above the next leading country. It's nothing to be proud of, and it costs a lot of money, and we do a huge amount of harm to humans. All of this, again, based on this early days of war on drugs and war on people. On that press conference you just saw, though, that gentleman on Nixon's left and on our right of the screen is Jerome Jaffe. And Jerome Jaffe was the first drug czar in our country. He didn't exactly have that title, but he really was the first drug czar. And I think he was a great guy. I have friends who knew him, and he has done amazing work. And he published this amazing article that everyone should read if you haven't read it. And it's his summary of the history of how we have regulated treatment for opiate use disorder And it was written in 2003, so buprenorphine isn't actually a big part of this article. I mean, that drug was approved in 2002. But it talks about the history of methadone, and a lot of what I've learned about the history of methadone comes from this article. So again, you go back and you read it when you're ready. Methadone's been around for a long time. We began using it, the Germans began using it for the management of pain during World War II. But in the 1960s, these three people at the Rockefeller University began using methadone for the treatment of people with opiate use disorder. And they were brave, and they were probably a little crazy, and they were radical, and they were studying tens of thousands of people, mostly in New York City. And one of the reasons I love them, and I love this slide, is because of the three of them, two of them were women. They both went to women's colleges, and this was back in the day when less than 3% of people in medical school were female. And Mary Jean Creek died almost exactly 1 year ago, on March 27th of 2021. So it's to these three people that we have methadone available, and they were amazing publishers of data and of research. And this is just a little selection of some of what they published, but narcotic blockade, a medical technique for stopping heroin use by addicts, studying 25,000 addicts with methadone maintenance, successful treatment of 750 criminal addicts. These are just some of the papers that they published from the late 1960s to the early 1970s. And methadone works. Like, I'm not going to stand here and tell you more than that. It works. It's extremely effective in a variety of ways. And study after study after study has said that. So we're not spending time on does it work or not. We're all moved way beyond that. So who in this room is a primary care doctor that takes care of chronic diseases? Okay, lots of people. And knowing, as a primary care doctor myself, all the chronic diseases you guys take care of, name some examples of some chronic diseases with which you might use a medication, and how effective is that medication? Yes? Okay, so the answer was statins for high cholesterol, and the response was not very effective. Okay, awesome. That's a heavily prescribed medication. Give me another chronic disease for which you routinely write a prescription. Okay, I heard both diabetes, insulin. I would say insulin actually is a very effective treatment because you're basically replicating what the body isn't doing, but I heard high blood pressure. How effective is treatment for high blood pressure? Lisinopril is an example of a medication one might use. So let's look at number needed to treat for high blood pressure. High blood pressure, number needed to treat over a 5-year period of time for the treatment of high blood pressure. To prevent death, you need to treat 125 people. To prevent stroke, 67. To prevent a heart attack, 1 in 100. So 100 people need to be treated over a period of 5 years to prevent a heart attack. You guys know number needed to treat. Those numbers, they're not the worst numbers I've seen for a number needed to treat, but they're certainly not the best I've seen. And as we all know, as primary care, if you're not paying attention to blood pressure, you're in big trouble, right? You literally get paid whether you manage people's blood pressure very well. The number needed to treat with methadone is actually a really hard number to find because it's a hard thing to study in some ways, but people, I don't know, people don't study methadone enough in some ways. So this is the best I could come up with. The number needed to treat with methadone, and it actually wouldn't give the time frame, and what I was able to find was 1 in 40 to prevent death. But for those of us who manage patients on methadone, let's pretend what you were measuring isn't death, right? The number needed to treat to actually get your life less chaotic, to have your life be better, to use no drugs or use less drugs, to not go to jail, to not be hospitalized, to not get a soft tissue infection, have money in your bank account. What's that number needed to treat? 4. Yeah, it's a low number. Somebody said 4. Yeah, it might be 4. I'd be more generous than that. It could be 2. I mean, people get better on methadone. They may not be perfect. And I don't look for perfect anymore. I look for improvement in health. Am I making you more sick or am I making you less sick? So the point of this is it's really hard to find a more effective treatment than in anything we do than the 2 agonist treatments for opiate use disorder. And thank goodness that those of us in this room get to help people who are sick and struggling with 2 awesome drugs, right? It's a great thing. The point of my entire talk, though, is we really need to get methadone into the hands of people who need it, and right now, there are many things blocking our access to it. So during that time that those 3 amazing people at the University of at Rockefeller University were studying methadone, Lots of other people were using methadone. So here's a drug, it's been around for a really long time. The FDA knew about it, and it fell into this category of an investigational new drug. Interestingly, those three said, it is not a new drug, it is an old drug, and we're not going to apply for that little status. We're just going to use off-label, and we won't apply for this. But a lot of other people did apply for it. During that 5 to 7 years of a lot of using of methadone to treat opiate use disorder, many things happened. So the FDA actually doubted whether it worked. There's one thing. There was something known as the Harry Anslinger influence. And for those of you who don't know who Harry Anslinger is or was, he died in 1975. He was the head of the Federal Bureau of Narcotics for 5 administrations. I guess that he was one of the longest serving individuals in the federal government. And he hated the addicts. He wanted to lock them up, knock them out, get rid of them. That was his philosophy, and I would argue that he is the original story of the war on people and the war on drugs. There was very strong pushback against methadone from communities of color who felt like it was government mind control. There was this very strong pushback that we still experience today from peer-to-peer recovery communities and 12-step programs about having, it's not real recovery, that you should have a drug-free or a treatment-free is preferred. There were clinics making money on the backs of people with addiction. You walked in, you had an opiate use disorder, and they said, give me 20 bucks, I'll give you the methadone, right? We've seen that all the time, actually, with buprenorphine and cash-only practices. There was treatment at the time of people who may or may not actually have had an opiate use disorder. That's probably not ideal. There was reports of an unlimited amount or quantity of methadone being dispensed. There were reports of children overdosing with methadone, and there were reports of diverted methadone. So this, for me, is what happens when new stuff hits the market. Crazy town, right? The Wild West ensues. We've all seen this, right? Name the drug, we've seen it. We saw it with prescription opiates. So in some ways, this was predictable. And as we know, sometimes when things happen bad in medical care, the pendulum swings, and it swings really far. And it's hard to imagine anything that swung more far than this and then stayed there, right? So for almost 50 years now, the rules were put into place on methadone, and they have not changed. We'll talk about Ingvald Olsen, who is speaking next door or upstairs or somewhere on this subject right now, and I kind of wish I had everybody here in 2 rooms at the same time because I need to hear what she's saying just as much. But so we will talk about this one place where things have changed just in the last 2 years. But in general, the pendulum swung, the rules got written, and they haven't shifted one iota in nearly 50 years. Laws get made. I'm not going to do the Schoolhouse Rock discussion about how bills are passed. But when bills are passed, the Code of Federal Regulations kicks in. And the Code of Federal Regulations are the regulations that govern the laws. And I think most of us actually don't know much about this. So CFR stands for Code of Federal Regulations, and there's a Code of Federal Regulation for everything. There's a CFR for energy. There's a CFR for aeronautics and space. So if you were bored one night and you were like, what are the regulations regarding aeronautics and space? You would go to CFR 14, and you would read several hundreds of pages of stuff that you may or may not understand on the regulations regarding that. This is what governs our federal government, okay? So food and drugs is under CFR 21. Everything is there. The FDA, every drug is there. The DEA is there. Everything is under 21. Did you guys know that? It doesn't matter whether you knew it. That's where it is. Weirdly, that's not where methadone and buprenorphine are, even though they're drugs treating human beings. Methadone and buprenorphine live under 42 CFR, the Department of Public Health. And in fact, under Chapter 8, they sit between the distribution of reference biologic standards and the standards of care for chimpanzees held in federally supported sanctuary sites. I've laughed at that before because it is funny, and then it's also horrifying. The care of our patients sits next to the care of primates. There's something profoundly wrong about this. And there's no other drug that exists outside of 21 except for these two. At the end of the day, this is crazy town. Like, I can't even tell you, again, rage. You're feeling rage? Everybody feeling that? This shouldn't exist, yet this is where the rules, the federal rules, on the management of methadone buprenorphine live. 42 CFR, Chapter 8, allows us to provide people with an opiate use disorder and opiate agonist treatment. And why did it have to exist that way? Well, this thing that everybody in the room knows, because most of you are board certified and you took your exam and they asked you about the Harrison Act of 1914 on it. And remember, the Harrison Act didn't say you can't prescribe opiates for opiate use disorder. It said you had to pay a tax to do so. It was when the courts reviewed it later that it began to put into question whether we really could use treatment of opiate use disorder. Could we use opiates? That was really the query. So the reason this exists is to say, look, we're going to move beyond the Harrison Act to allow prescribers to use opiates or other agonist treatment to treat opiate use disorder. The 1973 regulations, then, that are written in Chapter 8 of 42 CFR are very clear. You have to be 18 years or older, period. You have to have used an opiate for 1 year or longer. Now, there's many times that you all have seen a patient who's very sick, who has overdosed multiple times, who might have endocarditis, who might have a serious skin infection or compartment syndrome, but they've only been using for 8 months. They don't qualify for methadone. They don't qualify for methadone. And you can maybe somewhat get them in as a withdrawal management strategy, but you can't enter them in for chronic care. You will get in trouble, and that's if they find you out, but most of us get pretty nervous on that one. There's a maximum dose that you're allowed to use, and it's actually written in the rule, 30 milligram. I don't care how much fentanyl you're shooting into your neck, you get 30 milligrams of methadone on day one. The medical director can override it. You can get up to 40 milligrams. Counseling must be made available. There's limitations, and we're going to get to that, very specific limitations on take-home bottles, and it's a closed system. Only certain places are allowed to dispense methadone for the treatment of opiate use disorder. Narcotic treatment plans, also called OTPs or opiate treatment programs, hospitals, hospital pharmacies. That's it, nobody else. So the section on take-home bottles, this is just the language that says, again, you shall not exceed more than 30 milligrams of methadone on day one. You are allowed to have the patient come back and get another 10, I guess. That's a lot to ask of a patient to come back to a methadone clinic now twice a day. And the program physician can document that you don't think that that much is going to suppress opiate withdrawal, so you could go above it, but most people won't do that. And the 8-point criteria are utilized by the medical director to determine who actually is eligible for take-homes. And the take-home bottles are written in the regulations. Since 1973, they have not changed. So between 90 and 100 days of being in a clinic, and when I say being in a clinic, I mean being in a clinic and being perfect. You never miss a day, your drug screen has nothing in it, you have a house, you can't be living under a bridge, like all the things that make you meet the 8-point criteria. It takes 2 years of being a perfect human being before you get a full month of take-homes. You wonder why the average length of stay in a methadone clinic is about 42 days. What do we know about methadone? It works when you're at the right dose for the right length of time. In 42 days, if all of our patients with diabetes took their medication for 42 days, you think every government agency out there wouldn't be working day and night to fix that problem. So I'm just going to make a point that's obvious to everyone in the room, right? It isn't actually about the methadone, because for those of us in primary care who've managed chronic pain for a long time, many of us use methadone for chronic pain. I, as a family doctor, have used methadone for chronic pain for 20-something years. And what do we know about it? I can write a script for it. I can write it on a piece of paper. I can e-scribe it. I can send it to any commercial pharmacy. It comes off a shelf. It gets filled into a bottle and gets handed to you, the patient with chronic pain. There's no limits on how much I can use. I can do it, an NP can do it, a PA can do it, right? Except when you start treating opiate use disorder, right, all the rules change. So it has nothing really to do with methadone. Methadone for chronic pain belongs in CFR 21. Methadone for opiate use disorder, CFR 42. And if this is not clear discrimination on the basis of a disease, if this is not a violation of the American with Disabilities Act, well, I don't know what is, right? So what are we going to do? You're going to sue the government. That's the only way to really get this to change fast. And I've actually approached the Department of Justice about suing the government, and what their response was, look, we are the government. We really work hard on not trying to sue the government. And I was like, I hear you, but do you see this? And they're like, yeah, we see it's not fair, and it's discrimination. So again, lots of work that could be done right here on this very simple fix. Okay, so now we're going to dive in deep. Why is it so hard? What are the barriers? How is it that we can fix this? Because I think most of us believe the system needs to change. I don't need to convince you all of that. We got to get better. And these are the 4 very specific barriers to getting better. So let's go one by one. The first one is SOTA. So, who in this room knows what SOTA means? Awesome, smart people right here. Okay, let me tell you what it means. SOTA means your State Opiate Treatment Authority. Okay, now everybody knows what it is. Does anybody know in your state who's the head or who runs your State Opiate Treatment Authority? Awesome, good. Okay, people do, great. My guess is most people with their hands up actually are working deep in the methadone world. They're somebody who might run a methadone clinic. And so they are, or they're public policy people. Your SOTA matters a lot. And here's a job for everybody here. When we're done today, tomorrow, this week, I want you to look up who your SOTA person is. And it's on my list of things I hope that you get out of this. At the end of the day, we need to improve what is happening at state level for treatment of methadone. And a lot of this is run by your state. And who's going to change it? This room is going to change it, because you all have the power to do that. So there are 50 states, there are 49 SOTAs. The state of Wyoming has no methadone clinic. They do not have a SOTA. So the State Opiate Treatment Authority's job is to both interpret the federal regs and also to make sure they are active and in place in your state. I grew up in a house that was wallpapered in maps, and I love maps. I could give an entire talk that only looks at maps somehow and make it work, and so I'm going to torture you with a few map photos right now. This is a picture, obviously, of the United States, and those counties, the light blue counties, are places where there's buprenorphine, and the darker blue they get, the more buprenorphine there is. There's a lot of counties with nothing. I think there's people in this room who represent some of that big swath, the middle part of the country, where treatment is limited. The purple dots are methadone clinics. So from this map, I feel like I could walk out the door and walk to about 7 methadone clinics, because this part of Florida appears to have a lot of methadone clinics. If you zoom in, though, they're not so close. But on this map, it looks pretty good. Look at the Northeast, right? You should be able to get a methadone clinic, no issue at all. But as those of us from the Northeast can tell you, it's not that easy. So let's zoom in for real. If you look on the right of your screen, that is obviously the Northeast, from Baltimore through New York to Boston, lots of methadone clinics. Look at that map on the left, and that is the Midwest. So that's Ohio, Indiana, West Virginia, Kentucky. And you can see there's a lot of distance and a lot of drives and a lot of mountains and hollers and creeks in between those clinics. Overdose deaths per 100,000 residents. If you could just stare at the place where I just showed you that map, what we think of as the sort of coal belt or rust belt area, huge amounts of overdoses. The overdose rate in the state of West Virginia is 52.8 per 100,000 people. And you would think that that region, that map that we just saw, should have been filled with purple dots, because that's an area that needs treatment desperately. Opiate Treatment Program Directory. So you can go to the federal government, you can look everything up. State of Massachusetts has 91 opiate treatment programs. It's not exactly true, because you can be a withdrawal management program and you actually have an OTP license, but you're not a forward-facing public methadone clinic, so the numbers aren't 91 in Massachusetts, but again, we have quite a few methadone clinics in Massachusetts. State of Texas has 98. Anybody from Texas? Oh, the back, awesome, okay. Here's one of my favorite maps. That's the state of Texas. How many states can you fit in the state of Texas? I didn't do the counting, but it's a lot. It's a big, big state. Massachusetts is the size of Harris County, which is where Houston is, right? So it's a little shocking that little Massachusetts has almost as many methadone treatment programs as the giant state of Texas. And if I were from Texas, I would think to myself, that's not okay either. Okay, Your SOTA in your state has its own level of rules and regulations separate from the feds, okay? So you guys may have thought I was gonna stand up here and yell at SAMHSA. I was gonna yell at the feds. They're actually doing pretty well. We're gonna go ground up here. There's federal regulations, and then there's state regulations. And almost universally, the states put on even another level of barrier to access and care. So I want you, each time you're staring at these maps I'm showing you, to think about your state and where you are. So 20 states restrict the operation of new methadone clinics in some way or another. Those are the blue states. The state of West Virginia, one of the worst overdose states in the entire country, has a moratorium on new methadone clinics, and there has to be a certificate of need presented that is, I think, actually a pretty big barrier there. Indiana, anybody from Indiana? Same problem in Indiana. There's a limit. They say no more methadone clinics. There has to be a formally applied for certificate of need to get there. So already there are people in a day where more people are dying than ever before who are saying, nope, I don't want any more methadone clinics in my state. You could be administratively discharged from your methadone clinic because you use drugs. So those blue states are the states where they will permit you to get fired because you have marijuana in your urine or heroin or cocaine. It doesn't matter. You're fired from treatment. You're allowed to do that. There's only 2 states that prohibit being administratively discharged for using drugs, and that is the state of Massachusetts and South Dakota. There are 10 states that even have a higher level of what does it take to be considered stable to get take-home bottles. So they don't have the 8-point criteria. They have a 10-point, 12-point, whatever point criteria. I want afterwards during question and answers for people who live in those blue states like the South Carolina, California, New York, think to yourself, if you actually run an OTP, I want to hear what other level of halo do you need around your head to get your take-home bottles? Because I didn't do a deep dive on that one. But all I'm pointing out, my friends, is that this room right here can impact that. I'll be honest, there should be no greater barrier than what the federal limits are. We got federal problems that are big enough without the states piling on. So if your state's piling on, we need to have them pull back. Massachusetts in 2019 said, and I believe them, we're getting rid of all barriers that go above and beyond the federal. And then COVID hit, and then everything went sideways, and it didn't actually happen yet. So drug screens. The feds require 8 drug screens a year. Many states, including all of those blue ones, require more drug screens than that. Okay, so SOTA. Everybody's learned one thing, a thing that you can influence. Let's talk about the DEA. First of all, if this room were filled with DEA agents, I would still say the exact same thing I'm about to say. A lot of us are fearful of the DEA, and I understand why, because our ability to practice medicine depends on the license. I get it. And I'm scared of them sometimes too, but mostly, I'm rageful. I would argue that the public enemy number one to treatment is the DEA. This is a methadone clinic from the patient perspective. This is not one of my clinics, but my clinics look just like this. So this is me facing a dosing nurse. And what you see is a lot of things. You see that there actually are cameras everywhere. Those are locked, gated things that come down. There's always plexiglass in front. And you have security present 100% of the time. You can't be running a methadone clinic without having security on site. That's the rule. That actually is in 21 CFR. It's a DEA regulation. So right away, you're not a patient, you're a criminal, period. Right? My family medicine office, there's not security walking around. Yet I take care of the same people at both sites, right? But you walk into a methadone clinic and I tell you, right, you are a criminal, you're actually on probation, it's carceral control. Security is mandated by the DEA. The safe. You must purchase a safe of a certain size and weight. It must be installed in a certain way. When I applied to get to be a methadone clinic at my little jail, we bought the expensive safe and we locked it down and we did all the things. And they said, every time your safe opens, an alarm must go off at the police station. And I said, no, that can't happen. I'm a jail. And they were like, no, it must. 6 months later, back and forth and back and forth and back and forth, they finally said, okay, we hear what you're saying. You're a jail. You don't have to exactly do it that way. But every time our safe opens, an alarm goes off in central, and somebody says the nurse is opening the methadone safe, methadone is being removed, and it's being closed. But it took us 6 months to get through the DEA's restriction on that rule, and that's safe. I had to install a $30,000 anti-shake device at my methadone clinic in Springfield because a train goes by about every hour, and the building shakes just a smidge. $30,000. Really? Was that necessary? Security cameras. You have to have a security company 24/7, and they have to be able to see what's going on at all times. So I tried to open a rural methadone clinic in Massachusetts, the first rural clinic, and it was delayed by 4 months due to supply chain issues, and I couldn't get the right camera. So that's 4 months of people who desperately needed treatment not being able to get treatment. They like liquid methadone that is being dispensed from a specialized EMR. The DEA likes that, and I understand why they like it. It makes their job easier because you could hit a button and something gets printed out and you're able to keep track of everything. But these specialized EMRs that are associated with the liquid suspension cost a lot of money, right? This whole thing, all those little pictures I put up top, that for me is the methadone industrial complex. There is a lot of money being made running OTPs. There's a lot of people who have their own personal stakes in this system not changing. And for the group of us in this room that's like, that person up at the stage is lunatic, I don't think any changes should be made. For me, it's follow the money, right? I understand change is hard. And many people who are not supportive of the change are people like this who are making money on running methadone clinics exactly the way they are made. So another example at the jail is they said, we only want you to use liquid methadone. I'm a tiny county rural jail. And the company that wants to interact with our liquid methadone is going to cost me $10,000 a month. I'm not going to do it. The pills cost 61 cents a day. That's what we will be buying. I'm not saying the liquid methadone is expensive, but the machine the computerized program that dispenses the liquid is expensive. And again, it was a fight with the DEA, and finally, at the end of the day, we ended up winning that one. So you can see that there's a lot of money to be made in this. Okay, that was the DEA. We've covered SOTA. Let's talk about us, those of us who run methadone clinics, because we ourselves are our own unique problem. Let me just see it. I've been not wanting to ask, but now I'm going to do it. Who runs a methadone clinic in the room? Okay, great. Me too. Okay. In the federal rules, it spells out specifically that you must have counseling available. Let me read it aloud. OTPs must provide adequate substance abuse counseling to each patient as clinically necessary. That's all it says, actually, in the federal rules. It doesn't say you got to do this and that, and if they don't meet with you once a week, you cut them off. It doesn't say that. It just says if they clinically need it, you should provide it to them. It's actually really reasonable what the federal rules say. But that's not what patients know, I'll tell you that, because the way clinics make money, in fact, the only billable event in most methadone clinics is the counseling. That's it. So if the only billable event is the counseling, you're going to make sure that I see you in counseling as frequently as possible. So what we all know is patients say, I didn't complete my 5 annual groups, so I couldn't get the dose increase, the take-home bottle, whatever. The requirement for 5 annual groups is an urban myth. No one, your state may require, I can't speak to that. I only know my own state regs. There's no 5 annual groups. It's a place where my OTP can bill for the service to actually make some money. And the other pushback I'll give to you is it's awesome if you're doing 5 mandatory annual groups that really are life-changing, really important stuff for the patient, but most of the time, they're not. I'm going to say that. There's not a lot of evidence-based treatment, truly, CBT, DBT, seeking safety, acceptance commitment therapy, contingency management, evidence-based treatment for substance use disorder. Most of the time, that's not happening in most of our methadone clinics. Kind of mediocre care is happening, yet we mandate it. It is really hard to get in a methadone clinic. It just is. You call your local methadone clinic in today's days, and they're like, I'll see you in 3 weeks. This is a life-threatening emergency. They should be able to be seen in the next 30 minutes. If you and I were designing a system that was trying to save lives, walk in 5 days or 7 days a week. But methadone clinics don't work that way. Because methadone clinics are often staffed by those of us who have other jobs, right? And we're like, hi, I see patients 1.5 days a week, and if you can't get in that day, you won't be seen. I'll see you in 4 weeks. This is the way most methadone clinics work, and I love to hear from people afterwards that tell me that they run same-day walk-in services as many days of the week as possible, because that's really what you need. But that involves, remember, a doctor. The rule says a doctor. Now, you can have an NP or a PA waiver to do the work. That also takes some work. I love this one because this is me staying up late at night reading the regs. Everybody who starts methadone has to have seen the clinician, the doctor, I'm going to use that word, the doctor first, to do the physical and to make a decision about dosing. But what it really says is that a fully documented physical evaluation must be done by the program physician, my people in the room, or a primary care physician, who knew, or an authorized healthcare professional, meaning that's a waivered person who could do it. But the primary care doctor actually can do the physical. They can. And one of the things we've done in Massachusetts is, boy, once I saw that, I was like, darn, I think primary care needs to hear this. And what if I worked with primary care to say, look, you have a person on buprenorphine, they're not doing well, you know that, I know that, they know that, let's get them into methadone. Send me your recent physical, do a little summary at the end that says they've tried, they failed, precipitated withdrawal, they won't go back, they're using this much, we think they need methadone. That counts as their physical. That is a low barrier entry into treatment. Now, that primary care doctor can't write the order for the methadone. That's fine. That's on top of me. I'm the medical director of the methadone clinic. I can write that order. And based on this description that I am being told, they're going to get 30 or 40 milligrams on day one. That's what I would do, right? If they're 90 years old, I won't do that. But I'm not an idiot, and neither are they. We'll figure it out. So if you didn't know that, then now you know, because this could be a game changer. But you've got to have a relationship with your OTP and primary care to make that happen. Okay, dosing of methadone. People get better, the right dose for the right length of time. And a normal dose of methadone for many people is between 80 and 120. Some people need more, some people need less. It's a range. But normal, 80 to 120. Methadone clinics can be really slow about getting people to a therapeutic dose. It's a real problem. And I'm going to talk to you towards the end about what that looks like in reality and what a problem it is now, come in the fentanyl era. So my friends who run methadone clinics knows this form. This is the extranet form for SAMHSA. And so for you to file for an exception of any sort, you have to do this. And only the medical director can do this. So for those of you who aren't running methadone clinics, you have not had the pleasure of interacting with this form. So again, what happened when these rules were written in 1973 is they did this thing that had never happened, which they took away the clinical decision-making of a licensed, trained medical professional, and they said the government gets to make this decision. So when I see a pregnant woman who needs split dosing, which I see all the time, and I split dose them basically 100% of the time, I have to file a form online. It's like a 1982 form. It's not logical. And a bureaucrat in Boston and Washington, D.C. has to approve my medical decision. It's not a prior auth I'm filling out here, my friends. I have to explain to somebody my medical thinking to have somebody in D.C. hit a button and say yes. And this is for anything. This is, the other day I had a guy with dementia. He'd been on methadone for 20 years. He was going into a nursing home. I had to file and say, this guy's been on methadone for 20 years. He's super stable. Here's a chain of custody plan that I have with the skilled nursing facility, and he will go there, and their nurse will come pick up the medicine, and we have it all arranged. And I had to file. It takes me 12 minutes to do it. I'm busy. I'm irritated. I'm super passive-aggressive. I always do them. I use lots of big medical words. I like to imagine they have to stop and look things up that I'm writing about. And I have little cut and paste rageful language that I insert in this as well. And I submit these all the time. And if you're a methadone clinic that says we don't do this, you're committing malpractice as far as I'm concerned. There's people who fall in they need an exception range all the time, including the management of pain on top of opiate use disorder for which the trigger is pain. That is a split dose for me. I don't split dose 3 times a day, but I'll easily go to twice a day, and people get much more stable. So that's that. And you know what? This is not in the federal rules. I can't find this in the federal rules. This is just a SAMHSA rule. SAMHSA feels to me like they can get rid of this overnight and say, you know what? This group back here that knows how to run a methadone clinic, let them use their full licenses as a doctor to do their job without asking a bureaucrat permission to do their job. Okay, where are we now? We're at SAMHSA. We're at the federal government now. And so as you can see, our friend COVID-19 shows its beautiful head because as much harm, terrible, tragic harm as COVID has provided in the last 2 years, it did one thing really well. And that is for the first time in nearly 50 years, the rules and regulations of OTPs began to fall. And on March 16th of 2020, a letter came out. And this is the entirety of the letter. It has 4 little tiny skinny paragraphs. The entire letter is in front of you. And basically it said is, COVID is bad. Standing in line in a clinic with a bunch of other people, probably not good for your health. So if you're stable, you get 28 days of take-homes. And if you're kind of stable, you get 14. And the OTP directors were like, what? What is this? Because it just wiped away all the rules overnight. That's what it took. And what Ingveld Olsen is talking about in a room above or next door to us right now, because she's, I think, head of SAMHSA or second in charge of SAMHSA. She was my chief resident at Boston Medical Center back in the day, is that they're going to keep these rules in place, I think, for a while. That she can't commit forever, maybe, but for now, they're saying, we're going to keep these rules in place. And so that took away the mandatory time for take-home bottles. I am going to say to you that they did come out in November and came out with the delineation of who really qualifies. This is their November 18th letter from SAMHSA. Because a lot of us at OTP were like, look, we don't know what's stable, somewhat stable. What do you guys mean by that exactly? Although I felt like we knew what they were talking about. They came out with some very specific guidelines. The disappointment to me about these guidelines is that actually it does rely on drug screening, and it says you must have nothing in your urine. I'm not only am I ambivalent about that, I was rageful about that as well, and I sent them a long letter saying that is not the way we should proceed. People often get so much better on methadone, and they still use, but they use a lot less. They're not in jail. They don't have a spinal abscess. They have money in their bank account. They're holding down a job. They have loved ones who are supportive and now back in their life. I don't look for perfection. I look for improvement. I look for what the patient needs, and I work towards that. So SAMHSA could have done better than this, quite honestly. And the pushback that I've said and the way I'm interpreting the rules is to get 14 days of take-homes, I have to sort of come close to following their rules. But you can still have 6 days of take-homes. You can come in once a week and still have substances in your urine, but show other stability. Like, that's the way I'm interpreting the rule. I'll be curious to see how other ways other people interpret the rule. 4 big barriers, right? You guys know this. I think most of you knew some of these barriers. Some of you may have learned, wow, I didn't know that was a barrier too, or I didn't know quite how complicated this was or what the origin story was. And for us to get methadone where it needs to be, which is a lot of places right now, we need to actually have all of these walls start to fall, every one of them. So here's one thing. This is on us, those of us that actually make decisions about how to treat people with opiate use disorder in a methadone clinic. We are not getting people stable fast enough. And I think the problem is a lot of us are using what we used to do in 2010 or 25 or whatever, and we're like, well, this is the way I do it. I start them at 30, and I increase by 5 milligrams every 5 days, which is awesome, I guess, in a prescription opiate problem, but we're fighting fentanyl. And maybe some of your states aren't fighting fentanyl as hard as we are in the Northeast. But I've heard a lot of you from Philadelphia and New Jersey and all over New England saying that is all we have is fentanyl, and sadly, it's never going to go away. It's only going to get worse, right? The days of the Afghani poppies are distant days. We're never going to have heroin again in our lives. We're going to have some next stage of fentanyl. So if you're running one of these clinics, or you're soon to be running one of these clinics, the goal is to get people stable fast enough that you scoot them away from fentanyl. Because what happens is people start off too low, and they're doing this incredibly sluggish induction, and they just keep using all the time. And then they drop out of treatment because it's a lot easier to get fentanyl than to go to a methadone clinic. So this is a great document from our lovely Canadians up north. If there's a Canadian in the room, just know how much we love you. Love you. That's right. Thank you for that. And this is their methadone treatment for people who use fentanyl. It's an awesome document. They still start at 30 or 40, and I can be a little more aggressive than that. But the point is, it's a much steeper climb to get stable on methadone than it used to be. It is, and it has to be. And one of the things I've learned during the COVID era is that some of us are really risk adverse, and some of us are really risk tolerant. But what I say to my patients every day is, I know whatever I do to you is going to be a hell of a lot better than what's happening to you out there, because the stuff is so toxic, it's so poisonous, it's so deadly. So if you haven't changed your guidelines, your own internal how I manage methadone in my clinic, I want you to rethink it. I want you to read this document. I want you to talk to your friends and colleagues. And here they're talking about going up by 10 or 15 milligrams every 3 to 5 days, a much steeper climb than what we may be used to. I mean, how many times have you seen this slide this last couple days? Everybody knows it. Fentanyl arrived for us in New England in 2016. We now know that it's all 50 states, all the territories, and that big increase, that 20,000 person increase in death that we saw, 80% of it was west of the Mississippi. So again, these numbers aren't going to get better in terms of death. They're going to get worse. I don't know who thinks in the next 2 to 5 years it's going to get better. It isn't. It's going to be worse, which is it's just so painful for all of us, but more importantly, the families of people who've died. I'm not going to not acknowledge like the elephant in the room on methadone. You know, we talk a lot about dismantling structural racism in medicine. It is hard to find anything that is more like structurally racist than methadone clinics. They were intentionally designed that way. So this is sort of like the quote that you'll see. It's in this Harper's article. If you haven't read it yet, it's a worthwhile read. But it's John Ehrlichman, who was the right or left-hand person for President Nixon. And he said it very clearly. We wanted to associate the hippies with marijuana and the blacks with heroin. And then by criminalizing both heavily, we could disrupt those communities. You know, methadone was really designed to be an urban-used drug treatment program. And it was intended really to make it as criminal-like treatment as possible. We know very clearly buprenorphine is in white communities, methadone is in black or brown-skinned communities that are more urban. And it's structural racism at its worst. And if that is our goal, is to actually, in this time period, improve that, we have to dismantle this system. This is racial justice and national drug policy. There's a lot of people at this conference and other places who are much more expert in this than I am. But again, it's what I just said. Bupe for white people who have money, methadone for everybody else, and we're going to make it as hard as possible. I actually think this slide is so critically important that it's worth seeing it twice. We've caused harm to people. As you guys know, the number of people incarcerated who have access to treatment is really, really low. Did we hear it was 4% today? Some tiny, tiny number. For those of us in Massachusetts or those of us in Rhode Island, the fine, wonderful state of Rhode Island that had treatment, all 3 medications available as of 2016 for every incarcerated person in the fine state of Rhode Island, they'll tell you that 80% of their people are on methadone. They're not on bupe. In my jail, 80%, 90% maybe are on methadone. And it was hard to get our own license. It was a giant pain in the neck, but it was the right thing to do, and every day our patients at the jail are grateful to have access to that treatment. Okay, people are dying. That's the graph on the left. Only 20% of people who have an opiate use disorder are having access to drugs. And on the other side of the screen, you've got methadone and buprenorphine, some of the most effective medicines that any of us have ever prescribed in our lives. And then there's that giant gap in between. None of it makes sense. Super effective drugs, people who desperately need it, and a giant gap in between. And that's the work we have to do in this room. That's the work for every one of us and for our young people, like these young 20s and 30s-year-olds who are so smart and so capable and so harm reduction in nature. We have got to close this gap. And if we don't close this gap, you know, how many more people have to die? Another 250,000? Another 500,000? And in the time of fentanyl, there's no more effective treatment than methadone. I love bupe. I've prescribed it forever. It is harder to get on, and even when you're on one of these super high doses, it still may not suppress your cravings. Methadone works against fentanyl. It works against fentanyl, and we have to make it so much easier to get to. So what needs to change? Lots of things. The first thing is I actually think the federal government should have nothing to do with methadone, period. Your license is managed by your state, period. As a doctor, and I'm going to just say, doctor and PPA, whatever you are in the room, as a doctor, it is a state regulation. It's not a federal regulation. The DEA is federal, I acknowledge that. But the only medication that is managed by the federal government is methadone and buprenorphine. Now, to prescribe Accutane, do you need to have done a risk evaluation mitigation class? Of course you do, right? Some of us have that. Some of us are on the Clozaril REMS list for the federal government. I understand that. Mifepristone, the medication we use for medical abortions, it has some federal oversight over it, but there's very few drugs that fall into this category. It's a big ask, but you know what? Sometimes our job here is to make the big ask, get the federal government out of the management of methadone, let the states take over, and let the states show what can be done. Now, some people have done pushback on me and said, but the states won't do a good job. And I'm like, the states are already not doing a good job. But let us start from scratch, because there are going to be states out there that are like, we're going to come up with a different model that gets this medication available in a pharmacy, right? Because that big map we saw with all that blank in the entire middle part of the country, you think you're going to build a brick and mortar, $500,000 methadone clinic with all those DEA regs in the middle of, I don't know, name your state. Middle of Wisconsin, middle of Minnesota, the middle of West Texas. You can't afford to do it. It's too expensive. Smart, addiction board certified, smart primary care people who care about people with addiction can write a prescription. A medication like methadone could be dispensed in a pharmacy. Right now it's against the law. We all understand that. But we have to make some massive moves to get to a point where people get access. Let's talk about the small changes that could happen while we're waiting. So the first thing is, if you think your state opiate treatment authority needs to downregulate some of the rules that are layered on top of the feds, you need to talk to them. You need a meeting in the next 2 months with that person to say, we need changes now, and let me tell you what changes I think could help. The truth is, your soda person is probably totally in favor of it. They're just waiting for somebody else to jump on board. The sodas people are smart. I was on a meeting, I had the Washington State soda person, and we were in the chat box, and I was like, this woman's a rock star. And you could tell she wanted to make the improvements. If you're working in a methadone clinic right now, and you think you could make improvements in the way your clinic's doing things to have it be a little bit more patient-centered, to get more take-home bottles to people who should have take-home bottles, to have it be less carceral, to have it be a less miserable experience for the patients, please make those changes. You're in charge. You're the medical director, and the medical director has a lot of power. So I hope the overlords of whoever owns your overall clinic system don't really control you, and that you can actually improve things for patients, because only you are going to be able to do that. If you're the medical director of a methadone clinic, please apply for exceptions for your patients. Please do that. It's a pain in the neck. I know you know too, because I saw heads nodding. Just still do it, because it's the right thing to do for the medical needs of your patients. If you don't work for a methadone clinic and you work in any other setting, build a relationship with your local OTP and say, I want to transfer my in-hospital patients to you desperately. I want to start them on methadone in the hospital. I want to get them split dose because they're pregnant, and I want to hand them off to your OTP. Let's build that relationship. It should be the standard of care everywhere. I actually think OTP should be measured by patient outcomes, period. How easy is it to get in? How many minutes do you have to wait in line? Or hours sometimes. How long does it take to get to a stable dose of methadone? How long is the average length of stay in your clinic? These are reasonable questions to ask any medical treatment institution. These are questions that should be asked of every methadone clinic. And if your methadone clinic is falling way on the other side, something needs to change. Jails should be treated like hospitals. All jails should be treated like hospitals in the sense that hospitals don't need to do anything extra to use methadone. Jails should be the same way. If you're a jail that says, I need to treat with methadone, that is actually, from a federal level, that could just happen. Some of this is just like signing on a piece of paper. It can happen. And once that happens, then you don't have to be a jail that has to jump through 1 million hoops to dispense methadone, period. And I feel like there's so many smart people in this room that New York State can just make this happen. The other thing that can make it happen is just a state DOC. A state DOC, like from Colorado, could say, we're going to be the methadone clinic, we're going to hold the license, and every one of you out there is going to be a satellite clinic. And we'll have the addiction specialists on our end, and y'all don't have to do this work. No state has done this yet, but it seems doable to me. That's the end of my talk. These are my references. And I want us to have questions and answers and just talk amongst each other. Thanks, you guys. Okay, so you guys, I told you already, I'm not looking at my phone for the Q&A. Do I need to do that? Okay, yes. I'm going to repeat questions just because it gets recorded, okay? So he said two really critical things, and let me just summarize them. So his point was, if the feds got out of the way and let states take over, how do we know states wouldn't do a worse job? Well, some would. And in fact, the federal regulations on Wyoming, as an example, hasn't motivated Wyoming to have a methadone treatment at all. I mean, it hasn't helped them get one. If there was no federal regulations, would more states get better? Some states would get better. Would some states get worse? I don't know. I mean, it's hard to imagine things getting worse than the way they look currently in the entire part of the country where there's no treatment. But you're right. Some states, as we know, make decisions that we don't agree with. There's no federal rule that says you're mandated to do any treatment. So more and more states could say, we're not going to do any methadone. His other point is the one on, he's worked in jails where people have died of methadone. Methadone, you have to know a little something about methadone to use it. I will acknowledge that. And if one were to do an 8-hour training on anything, it should be methadone, right? Bupe, whatever. But there was something useful. And in fact, you can imagine a world in which one would say, actually, to prescribe methadone from a primary care standpoint, right, you actually do need to have done a training, and then a lot of us would sign up for it. Lots of us would do that training, and then we would do it from our primary care site. And that's something I think that ASAM could advocate for. Yes?
Could I carry a microphone around with me?
I would love that.
For the next.
Yeah, I'm just going to ask the microphones. We can use a microphone. I love that you're going to do that. I'm being hesitant because I don't know how to use the microphone. Just let's make sure it's on. Is there a button? So in the back, I'm going to have you shout out while we're trying to get the mic on, okay? Let me take the one in the white shirt first, and then the one behind second. Yep.
Hi, I'm Gavin Clark. I'm from Healthcare in Minneapolis, Minnesota's largest safety net system. I want to recommend or commend to you a webinar that the National Academy of Medicine put on the beginning of March on methadone regulatory reform. There are many things in the works, so I think change is afoot. But I also want to point out that there are currently existing regulatory allowances that OTPs do not take advantage of. For example, interim methadone treatment, medication units, mobile methadone, all of these things are allowed as of today. You can do them, but very few OTPs actually do them. So if you are running an OTP, these are things you could begin doing now and that can expand access to treatment. So please consider taking advantage of what the regulations currently allow you to do until we wait for further regulatory reform.
That is excellent, excellent point. So he is advocating for a 2-day fabulous conference that the National Academies did put on with all the superstars. And I left that 2-day conference. I attended all 16 hours of it, and I missed none of it. It was excellent. And it's on their website, and there's like a YouTube video. You can watch the whole thing on double time. But there are tons of really important people out there who recognize this also needs to change. And how to do it is still a little bit in question, but it was excellent. And then his point is that some of these things already exist, but nobody does them. So exactly. Keep advocating. And again, that's stuff at a soda level that could be influenced and encouraged. So right behind him.
Yeah, thanks for your lecture. I agree with every point that you made, but the kickback that I'm going to get and that I've gotten before is there was that disease process a few years ago where we let physicians make their own decisions about what narcotics to give to patients and how many narcotics to give to them. I think it was called chronic pain, and you guys didn't do a very good job with that. And here you are saying, you know what, that was just a blip. We're going to do a much better job with this. Please get off our backs because we want to take care of patients.
Okay, so I think that's fair. I think it's a fair thing to say. Having said that, the amount of training I got in managing chronic pain during my medical school and residency was 0. And then I got launched out as a primary care doctor in the late 1990s, not knowing anything except for big pharma telling me it was all safe and no one would get addicted. I think we can do a better job with that with methadone. I think we can acknowledge there's people who would benefit, people who won't benefit. We need to teach ourselves how to dose appropriately. We need to understand who might be high risk and is a bigger concern. And I guess I think most of us are smart people who don't want to hurt people, and I think for those of us that managed chronic pain, a certain contingent got addicted, a whole bunch of other people actually got help by chronic opiates and cutting everybody off, let the pendulum swing too far the other way too, which wasn't great either. We are so extreme in our response to things at times, but I hear what you're saying, I hear the pushback, and yet 100,000 Americans are dying every year. Something has got to change, and we can't wait 4 or 5 more years to make that happen. Yeah.
Do you think there are differences in functioning outcome between buprenorphine-treated patients and methadone-treated patients?
I take care of both in the same setting, and people do great on both drugs. And so I guess I don't know. I have people who drive trucks and work full-time and manage everything pretty well equally. So tell me what you're thinking. You seem like you've had experience the other direction.
Yeah, I used to be the medical director of a methadone program, and now I primarily work with buprenorphine. And my experience is that fewer patients on methadone did jobs where they were putting money away for Social Security. It was more under-the-table work or criminal things to support themselves. And patients on Suboxone seem to function better, I think.
Well, there's a part of me that wonders whether showing up every morning at a methadone clinic at 6 or 7 a.m. gets in the way of so much of normal life. And that what if we did a study of everybody coming in, let's say once a week or twice a month, and then see how well they function? I feel like we're part of the problem. That's what I will say. I mean, I run these places. We're part of the problem.
I just wanted to, for a moment, just encourage any people of color and LGBT people or people who are serving those populations to ask questions if you could. Thanks. Next person.
There's one in the back corner.
First of all, thank you so much for the talk. I appreciate your passion and your anger. It resonates with a lot of us, including me. I'm an internist and addiction physician for Housing Works, wonderful organization, and a harm reduction clinic in the Bronx. As Dr. Cunningham pointed out, the worst congressional district as far as underserved. So I'm lucky to be a part of a lot of good advocacy groups in New York and physician healthcare groups that are just all about advocacy. During COVID, we did it for buprenorphine. Methadone, a key message you kept saying was we just need to get the federal government out. And one key step that you asked us to do, find out who your SOTA is. I'm glad you said, I actually don't know, so I just looked it up for New York. What else can we really concretely do? Because as healthcare professionals and physicians, we are the second most trusted profession, second only to nurses, so get them involved as well. And when we say something, people listen. For the most part, they really do. Other than contacting our SOTA person, what else do you recommend to really getting the federal government out of this? And I believe in sharing stories, science, and storytelling. I agree with that. But if you have any other specific, concrete things that we can do, please let us know.
Well, I actually think you should also be in contact with your elected officials. So Ed Markey is my state senator, Ed Markey and Ryan, I guess. Was it right? It wasn't Ryan. Who was it? I think it was Paul. No, it wasn't Paul Ryan. Was it? Have a bill out there that is it going anywhere? I can't really tell because it's the government process of having legislation passed. But in Massachusetts, a little group of us who were people who use drugs and people who advocated for people who use drugs got together, went to Ed Markey and said, we need help. And he has a bill out there to basically get methadone available in pharmacies and to down-regulate everything. I tell you, New York State can change things. You guys are powerful. You have an amazing, Dr. Cunningham. You have people who are game changers who could make the change. What we're asking of our local legislature is to ask the state to get a whole statewide exception from being under the federal regs. Do I think that's really going to happen? Maybe not, but we're going to ask. What if New York State said, you know what, we don't want to have the federal regs apply to us. Let us do what we want to do. Let's make the ask. We got the right people running SAMHSA right now. It's a good time to ask. And then New York State could show a way of going forward that looks different and actually measures outcomes and patient benefit. I think that's a suggestion. Statewide exemption from the federal rules. How'd that be? Any other states want to sign up for that? I mean, there's a lot of states out there who would do it and need it. There's one in the back over there. And I also recognize it's past 2:30. If people have to go, I will not be offended. Yeah.
Rural America talking here. We're one of those counties with buprenorphine prescribers, us, and no purple dot. The nearest methadone program is an hour and 20 minutes away from our home. the number one qualification for methadone in our county is not having or wanting a job. That's got to change. Don't know how to change it, but it's got to change.
So I missed the last part that you said.
Okay, let me unpack that a little bit. At an hour and 20 minutes each way to the nearest methadone program, the only way to get established in a methadone program is not having or wanting a job. Because driving an hour and a quarter each way every single day, 6 days a week, is incompatible with employment.
Absolutely it is. It's incompatible, and that's on all of us that support these regulations. Absolutely it is. You can't work if you have to have a 3-hour commute to get daily treatment. It's unacceptable.
So underlining your message, this must change.
Got it, absolutely. And again, the methadone vans are a good idea until you actually dive into the methadone vans, because if the DEA is involved in the vans, which they are, they're going to have that safe, they're going to have the security, they're going to have the cameras everywhere, and what if your van breaks down? My friends, if your van breaks down, people miss their methadone. I had a talk recently on the one program I knew of in New Jersey that was using a van. They said, don't buy a van, get a flatbed truck. Because then you can slide onto the flatbed truck, the clinic, and when the truck breaks down, it has to go to the shop, the flatbed comes off and then goes to a different truck. And I was like, oh my God, that's the best, most logical advice imaginable, right? Because I tell you, as a person whose cars break down, your methadone van's going to break down, and then people will be in a tough way. So it is a solution to a totally screwed up system. And what if we unscrewed up the system? You don't really need a methadone van then. So thanks, everyone. Have a great rest of your conference.